Hi everybody, and yes, my plan over the next sort of 25 minutes is essentially to talk to you about frailty. I'm not going to cover everything, and for some of you, this will be stuff you are expert in. Some of you, it'll be stuff that's might be a bit new. Plan is to talk about what frailty is with a slight anaesthetic perspective, and talk about how we can assess frailty. And then, particularly building on the work that we did with SNAP3, having a discussion about how living with frailty affects perioperative outcomes, and then a bit of thoughts about what we is quite a wide term, about what we should do around about frailty. So, cracking on. Frailty, what is it? Well, there are lots of definitions of frailty, and this is one of the less wordy ones. It's an aging-associated syndrome leading to increased vulnerability to poor outcomes, which in longer words basically means that people who are living with frailty are more likely to have an adverse outcome in response to smaller stressors. So a chest infection might not make you or I liable to a poor outcome in the long term, but if someone who's frail, that of itself may be enough to sort of to knock them down in terms of adverse outcomes. And adverse outcomes, we're thinking about things like requirement for admission to hospital, requirements for increased care at home, mortality, all those sorts of outcomes. But that's all very wordy, and I probably haven't made it make sense to you. And in terms of making that make sense to our patients, there's a brilliant analogy from a geriatrician in Scotland called Trish Elliott, who talks about the paper boat and about the fact the paper boat might look fine, so your patient might be coping just fine at the moment, but that paper boat is really at risk of anything that happens to it. If if a wave on a pond was to come over that paper boat, it's not likely to recover. So it's quite at risk, even though at the moment this person who's living with frailty may be coping okay. Little events may make that more difficult, may lead to sort of adverse outcomes. And if you want to see a bit more about her blog about this, scan the code. In terms of frailty, there are two main models that people talk about in terms of this syndrome. There's the so-called phenotype model, and then there's the accumulated deficits model. And the underlying causes is, as always with all syndromes, and particularly aging-related syndromes, it's multifactorial. So I'm just going to take you through a couple of the models because it does affect the way things are assessed. Oh, actually, no, I'm going to talk to you about pathophysiology. So I say lots of things which affect that paper boat, I suppose. And some of those are inherent to the patient. Some of those are a consequence of just the fact that their biology has got older. Remember, this is an aging-associated syndrome, but also some of it is related to the environment. Frailty affects people from from more deprived areas earlier than it affects people from less deprived areas. So our environment, our upbringing, all of these result in this syndrome of frailty. Inflammation or inflammaging, so this sort of low-grade inflammation which happens as we get older, is thought to be a key driver. So I've sort of hinted at this a few times that frailty is a syndrome associated with aging, but it is not the same as, and it's not synonymous with biological age. So just because someone is older, that puts them at greater risk of living with frailty, but doesn't mean that they are living with frailty. Younger people can be living with frailty, and so age of itself not the same as frailty. And similarly, multiple long-term conditions, which is the sort of the current parlance for what we often talk about as multiple comorbidities. So people living with diabetes or hypertension or all of those things which we write down in the anaesthetic chart, having multiple long-term conditions clearly associates with frailty, but it's not the same. And I think this is partly speaks to our understanding about frailty as anaesthetist, that we need to get beyond just essentially saying, do they have well-controlled diabetes? Do they have well-controlled hypertension and so forth? So multiple long-term conditions, most people with multiple long-term conditions are not living with frailty. The majority, but not all people living with frailty have multiple long-term conditions. They're not synonymous. And importantly, disability is not synonymous with frailty. These are distinct conditions, and this is one of the issues during the pandemic when people started using talking about using the frailty scale as some sort of marker of who should get various levels of care. That quite rightly, there was a pushback, absolutely rightly, saying that there was a risk of misusing frailty assessment to make judgments about people who are living with disabilities, which are again they overlap, but they are distinct. So that's a bit about frailty. So the models, I did say I was going to talk about the models. So there's a Fried phenotype model, which is sort of the one you sort of see, I suppose, in some ways, where they talk about these 5 factors: unintentional weight loss, exhaustion, low physical activity, slowness, and weakness. And that's operationalized such that if people have 3 or more of those, then they are defined as being frail. It's sort of like this dichotomy. Or this accumulated deficits model, which is essentially saying that someone who's frail across multiple domains will have more things which aren't going right. So that might be to do with in their social domain, it might be a cognitive domain, it might be to do with their physical domain. So, and essentially says if you just keep asking questions and you ask 30 questions, what proportion of those things where they could be okay or they could not be okay, what proportion of those have they lost function or lost in each of those domains? And as you might imagine, the more questions you ask, perhaps the more granular it becomes. But it probably doesn't really matter how many questions you ask, as long as you ask enough and you ask them across the domains. And we see that in this accumulated deficits model, that in something called the electronic frailty index, which is widely available from the GP record. It's a system which uses it's an automated system, but hasn't really penetrated into hospitals. But there's questions about whether it should. There's the frailty index itself, which is what I've described, and then it's been, I say, operationalized into what many of you would have seen, which is common, which is a clinical frailty scale. So that leads me on to assessment of frailty, because it's all very well knowing what frailty is, but how do we actually recognize it in practice? So I'm hoping that a few of you are still listening at this point and you've got your fingers over the buzzer. So I'd like, if you can, because I don't want to know who says what, but if you think this lady is frail, can you click the thumbs up button on the react thing on Teams? Let's find out whether there's even one person listening at this point. Lots of people have hitting the thumbs up, and anybody think that she's not frail? Take your thumbs up. One person. Okay, so what I'm going to tell you about this lady is that I have absolutely no idea whether she's living with frailty. I can tell you a few things from this picture. I can tell you that she's in a hospital gown, an old one by the looks of it, and she's older because she has we can see the signs on her hands and her face that she's older. And I can also see that somebody dyes her hair for her. And that's it. That's all I can tell you about this lady. For all I know, this lady might have been in hospital with a fractured ankle because she was running to collect her grandchildren. The reason she was running is because she was late, having been sorting out the finances for her local charity. That might be the reason why she's in bed. Or, equally, looking at her, she might come from a nursing home and perhaps have told you exactly the same story, all of which is untrue, and she actually fell out of bed and doesn't remember a thing about it. So, an end of the bed assessment is not the approach that we need to take for frailty. It's not an end of the bedogram, and that's really important. As I've said to you before, it's a multi-domain approach. When we're looking across the systems, we're looking at the physical side, we're looking at the social side, and we're looking at the cognitive side. Ideally, we need to stretch back. We're not thinking about the acute event because essentially, if I do anything to anybody, put them in a hospital bed, they start to look frail. And they may well be frail in terms of, or have attributes of frailty at that point because they can't do the things they were doing before. So we need to look back. We need to be asking questions about what the person is functionally able to do over the last couple of weeks before the acute illness. And one of the key questions to ask about is slowing. Are you just slowing up compared to what you used to be? And I said that's The high levels of frailty are perhaps easier to define, but the lower levels of living with frailty, that's one of the key questions. Are you slowing up compared to where you were before? So this is my, I've got two annoying questions. Well, I've already asked one, but anyway, here's another one. Right. Can I have thumbs up again again, this is all anonymous, which is brilliant. Do you routinely assess frailty in your clinical practice? So quite a relatively small number of people, which is it's a completely honest answer. Thank you for that. Are assessing frailty in their clinical practice. So this is the clinical frailty scale, which I suspect most of you have seen or I've heard people talking about CFS, and this is the most widely used tool. It's not a perfect tool. Like all things, it has a degree of subjectivity, but it's the most widely used. It's what's used at NUH, and it's what's used. It's what's naturally recommended for essentially for all older people over 65. They should have a degree of frailty assessment. Now, here's my next question. And regardless of whether you do or whether you don't, I'm hoping by the end of this talk you're going to think that frailty is important. So again, honest answers. Have you been trained? Has anyone been trained to assess frailty? So here's my little challenge to you. I'm going to suggest that assessment of frailty has more an impact than knowing how to use a stethoscope. But we've spent 5 years at medical school being trained how to use a stethoscope, which to be fair, most of us have forgotten. But actually, I think assessment of learning how to assess frailty properly and to talk about frailty, I think it's really important. So I'm going to encourage you all to get your phones out right this minute. And I know you love to do some mandatory training, and this isn't mandatory, and I'd be shocked if I suggested it was. But the good news about this is a really good, and it's really quite short. And I honestly did it. I think it's educational and it's well written. It's a little tool to look at how to use the clinical frailty scale properly, and it applies to perioperative context. So this isn't just something quite abstract. And the really good news is at the end of it, you get a certificate which you can show your appraiser. So there you go. Just take a snap of that. Right. Frailty assessment. Okay, so there's a bit about you, but also it's not just about you, it's about what the whole system recognizes and thinks about frailty. So what we can tell you, I'm going to talk a bit about some data from SNAP3, not just about NUH, is that the answers you gave earlier about how many of you assess frailty, even if you put that into system context, where you might expect preoperative assessment and so forth to assess that, certainly these data, which are from a couple of years ago, suggest that we're really not very good in the perioperative setting at routinely assessing frailty. And if we only assess frailty in people where we think they might be living with frailty, then we're going to miss people who are living with frailty. So it's not routinely done. So there's a challenge for us as individual anaesthetists and as a hospital to make sure that actually that information is actually getting into our brains and we're thinking about the pathways that might happen. That's all very well, Iain. Yeah, fine. Frailty, yeah. But does it actually matter? Well, I'm hoping that you're going to come away from this thinking that frailty does matter. So SNAP3, big study which NUH took part in, which we led nationally, looked at about just over 7,000 patients, all comers basically having who are over 65, over 60, having surgery, elective and emergency surgery of all comers. The only major thing that got left out was cataract surgery. We felt that was just overwhelming the system with a particular specialty, and a particular operation. So out of all of those patients, including day cases and inpatients, about 1 in 5 of those patients are living with frailty. And I've just given you an example here from the colorectal group, where you can see that unplanned surgery has a higher prevalence of frailty than elective surgery. But this is an issue where 1 in 10 of our patients are living with frailty. And frailty here is defined as a CFS above 5. And I'll come back to that that distinction in a moment. But these, as you might imagine, these figures are essentially replicated across all the specialties, but pick colorectal out as one of the larger surgical specialties, which applies to pretty much every hospital in the country. So does it make a difference? Well, here you go. This is the impact of and this is an adjusted model. So this is taking into account age and urgency of surgery and a lot of other factors which you might expect to influence outcomes. taking all those other factors into account, yes, frailty is associated with worse outcomes. And we looked at a variety of outcomes and we're still looking at these. So this is length of stay. But one of the things I want you to take away is that CFS4 group, which is the very mild frailty, or in old terms, the vulnerable group, sort of below that cutoff, their risks of adverse outcomes start to go up as well. So it's not just the sort of the people living with really quite marked frailty, but the people at the lower ends of frailty are also associated an association with worse outcomes. I've already alluded to this sort of question about slowing up. So CFS4, living with very mild frailty, these are the patients where if you don't ask them, are you basically slowing up? Because CFS 1 to 3 are basically completely fit older adults, where it's just a question of how fit they are. But just that question, are you feeling slowed up? Are you getting tired during the day? That's one of the key markers of someone who's CFS4. About delirium, a big interest of mine and colleagues here and across the country. Well, the risk of delirium again goes up as frailty goes up, and again it starts going up as soon as we're starting to live with even very mild frailty. Mortality similarly associated with frailty as we go through. So frailty, I would suggest to you, is a really important marker, probably more important than ASA, which we routinely write down in this patient group, but we need to assess it properly. So what are the implications? Well, I think there are implications for individual clinicians, us. There are implications for our perioperative pathways, and there are implications for society, which we are all part of. So for us, for you and me in our clinical practice, when you're going off to your list this afternoon, just thinking about how we actually consider frailty in our practice. What do we do with it? Do we seek out that information? What do we do with that information? I think talking about frailty is difficult. This isn't about saying and getting the terminology right. Frailty is a medical concept. People don't like being described as frail, which is for understandable reasons. Hence, that paper boat analogy might be useful to you. And for us as anaesthetists, I think we can rightly at times be criticised for thinking that everything's fine, provided the patient gets out of recovery with a blood pressure and a pulse and is analgesed. And actually, we need to be, particularly in our assessment, thinking beyond the recovery room door. What's going to happen to these folk after hopefully when they go home, and what's their recovery going to look like? Because it's not just about getting them out with that first post-operative day. In terms of pathways, we need to get frailty and delirium screening as routine. It's not, and screening is fine, but unless we're actually acting on it, and we've got a pathway which thinks, well, what do I do with this person who's living with frailty, of whatever severity? We need to get those pathways right. And I've got conversations coming up with Thea and with Iain about what we perhaps could do at NUH, and I'm sure you've got really good ideas. The POPs model, that's something that's run from set up in London, which is essentially a wraparound physician, so geriatric physician-led service from preoperative and post-operative. There's some evidence behind that POPs model, and we're trying to implement some of that in the emergency laparotomy pathway here at the moment. And it's about getting the right expertise in the right place. The wrong answer to all of this is to say everyone should see a geriatrician for lots of reasons, but nothing else. There are simply not enough geriatricians to do that. And I think there is a challenge for us at NUH and across the board to what do we do about those patients who are living with very mild frailty? How do we essentially optimize their passage through the surgical pathway? In terms of evidence-based interventions, there are a few. Comprehensive geriatric assessment, which is essentially the toolbox that geriatricians use, and it's not just assessment, it's also management and planning. There's an evidence base behind that. There's good evidence base in hip fracture that it works. And as I said, that POPs model, which is Jagdeep Desi and Jude Partridge have pioneered down in London, and there's evidence that works. Whether we can make it work at scale is another issue. And that's similar to the Scopes model. For those of you who are a little bit older, might remember that we had here. So there's evidence for those models. For those who are prehab enthusiasts, there isn't, if I'm honest, in terms of when it comes to looking at the patients marked as living with frailty, the jury's out really in terms of perhaps it reduces, prehab might reduce complications, but in terms of sort of the possibly more important outcomes in terms of mortality or need for readmission, the data just aren't there in either quality or in quantity to say whether targeted prehab for this group is of benefit. This is a problem that's not going to go away. I just put the slide up just to remind everybody, these are old projections, but as I'm sure everyone except perhaps the pediatric anaesthetist is fully conversant with it in their practice. The older surgical population is getting larger and it's going up faster than the aging of the population as a whole. So we are seeing a greater proportion of a greater number of patients coming our way. What about society? Well, we're all part of society, and I think we need to start having proper conversations within society about what it means to be an older person living with frailty and what actually matters to an older person living with frailty. And I certainly don't want anyone to go away from this talk thinking that someone who's living with frailty shouldn't be offered the option of surgery. That is going to be the most appropriate option in a lot of patients. But for some patients, it might not be the right option. And that burden of surgery in the peri and the surgical pathway may not be what they want. And one thing we're not very good at, I think, as anaesthetists, is because we don't have the information, is understanding when surgery isn't the right option. What do we do about that? What are the other options? And have we got the pathways in place? Surgery might seem like the easy, we can do something option, but actually making sure we understand what would happen if we don't have, if surgery is not happening. So, in summary, around these are the data from SNAP3, which hopefully you can take away. So, around 1 in 5 older surgical patients are living with frailty, whereas about half are multimorbid, which is a distinct thing. And the patients living with frailty, it impacts their length of stay, impacts their risk of delirium, impacts their risk of mortality, we need a whole pathway approach to thinking about how we manage frailty, both right from the start, from primary care, that preoperative phase. There's a bit of stuff perhaps we can do intraoperatively, and then think about what's going to happen to them afterwards. If those of you are interested, you want to read the papers. Those are the papers. You can scan the QR codes, and there's more papers coming out if you're interested. And obviously, contact me if you want a copy. That's fine. And finally, just say thank you very much for listening, and to also say a big thank you to Claire Swarbrick. I'm sure you can work out which one's Claire. This is Claire at her PhD graduation earlier in the summer. Claire is an anaesthetist down at Exeter, who was the trainee lead for SNAP3 and basically did all the work which led to what I've talked to you about. So a huge thank you to Claire. And that's everything.